So our next speaker is Dr. Saki Hanifa. He's a consultant cardiologist attached to Teaching Hospital Karapitia. He's going to tell about the treatment strategies in heart failure. Over to you, Dr. Hanifa.
Are you all awake? Right. Hope everybody had a good breakfast and tea and everything. I think Nilishka made my presentation a bit easy, discussing the pathophysiology, causes and everything. We will discuss on treatment strategies in heart failure. I slightly modified it to chronic heart failure because the time is just 15 minutes. So if you were to discuss both, it will be an issue. So I'll base my talk on these two latest guidelines, which is Heart Association, the American Heart Association and the ESC, European Heart Association, 2021 and 2022 guidelines. So it might be slightly boring. The classification of recommendation, that is something we always discuss because it's an evidence-based medicine. I think it's a time that due to our economic crisis and everything, we should cater the international arena as nursing officers or LL medical professionals. That is why we conduct these forums in English, and we should also be familiar with what the world is going ahead. So these are the recommendations. Anything which is coming on the green color, that is a class 1 indication, right? That is, if there is no contraindication or no other compelling reason, you should administer this treatment. That is beneficial. The class 2 has two varieties, class 2A and class 2B. Class 2A is, it should be administered. We should consider always, to administer. And class 2B is a less strong evidence in the clinical medicine. Class 3 is harmful. We should avoid this treatment. So definition, a previous speaker was nicely explaining that. But the second part is, it is very important to know if you are learning something, why it is important, right? So if you are learning about heart failure, why it is important to learn? Why should we prevent or treat heart failure? So it is about 64 million people are living worldwide with heart failure. Out of them, almost like 50-50 is around diastolic, we call it a heart failure with preserved ejection fraction, and another half is heart failure with reduced ejection fraction. So 64 million is a very big number, and we are also not immune to this. Any of us can get a heart failure at any time in our lifetime. It is, say, 1 in 5 risk of heart failure during our lifetime. So prevalence is around 1 to 2% globally in the adult population, and it has a very high mortality. That is another problem. If you do not manage or prevent heart failure properly, we can die about 50% of the time. The 5-year mortality is around 50%. So this is what we say is compared to a worst cancer, heart failure is worse than the worst cancer. It's the worst. So that is the reason why we should know heart failure properly, how we manage. So this is basically the diagnostic algorithm that we talk. So if a patient who comes with heart failure risk factors or symptom and signs, so if there's any abnormal ECG, we can go for a BNP test. But unfortunately in Sri Lanka, it is not widely available. In Colombo private sectors, we do have, but it is sorted out here. If you do not have any BNP levels, then you can straight away go to the echocardiogram, right? Echocardiogram will give more details. It will diagnose heart failure, and also it can give the idea about the causes as well. So if it is both are normal, if the BNP is normal, if the echo is normal, then heart failure is almost excluded, right? Then you go for, if the echocardiogram abnormal, then you go for, it confirms the heart failure, and we can classify it according to the ejection fraction with preserved ejection fraction, mildly impaired ejection fraction, and reduced ejection fraction. There are 3 categories. Then you can determine the etiology, or if it is acute presentation, you can even determine the precipitant causes, right? And you can start on the treatment. So this is another thing that we should know. If one patient is diagnosed with one condition, above one of 3, it doesn't remain the same all the time. It can change. Either it can improve to the, say, for example, if it is a reduced ejection fraction, it can remain the same, or it can improve in course, like heart failure with mild ejection fraction. There are conditions like, say, myocarditis and all that can improve. Totally it can improve sometimes. Peripartum cardiomyopathy is about 50% of the time. It can come back to normal. So, this indicates we need to have a serial assessment of these conditions. Rather than diagnosing, putting a label, say heart failure with reduced ejection fraction, it doesn't remain the same all the time. It could or it could change. Either it could worse or improve. So this is another important thing. This is the base where we stage the heart failure, and depends on this staging only we are going to discuss the management, what the treatment that we are going to offer. So this is very important to know heart failure at risk. This is called primary prevention. This part, I think every one of us has a role to play. If you do understand the risk factors, for example, the commonest risk factors are hypertension, ischemic heart disease, diabetes, obesity. So this is the risk group where the patients are having another condition which can lead to heart failure. So it is very important to identify these conditions, treat them properly, and you prevent heart failure. So once the heart failure with reduced ejection fraction due to these causes occur, it is very unlikely that we can turn around a lot of things. So it adds to the healthcare cost a lot, especially in Sri Lankan setting. We should be cost conscious in treating these patients. Secondly, the pre-heart failure, where the heart is, there are risk factors, but there are the structural and the functional changes. The previous category, the heart is absolutely normal. But in the second category, the heart has structural or functional problems, but still the symptoms are not there, right? So this is another important group. Their prognosis is good if you identify this group and treat appropriately. So this is another group we should be very careful. Third one is the symptomatic heart failure, where there is a structural or functional deformity and the patient coming with the previous described symptoms. So this is this is sort of a progressive sort of worsening of heart failure scenario that we are talking. The last one is we are talking about the advanced heart failure. We need a lot of device therapies that is to provide this appropriate care. We will discuss in a moment about those. So at-risk group, so as I said, if you identify hypertension, you need to appropriately treat the hypertension. So there is a new group of drugs that we are using in Sri Lanka for a few years, but it has been there in the world for the last decade or so. So it is if there is a heart diabetic patient who are coming with ischemic heart disease, this SGLT2 inhibitors, which are dapagliflozin or empagliflozin, this treatment prevents the heart failure, progression of ischemic heart disease, and the hospital admissions all are prevented. So this is one group of medicine as nursing officers, for example, once they are being discharged. So you should check, ask the doctor, this patient has a diabetes, now coming with MI, why don't you prescribe these medicines, right? So patient with cardiovascular disease, you need to optimize, the antiplatelets, statins, those treatments should be there. And the patient exposure to the cancer medicines, we need to have a multidisciplinary team meeting, then serial assessment and manage appropriately. First degree relative, there are a lot of genetic heart diseases. So many things can occur from these things. So that is the sort of at-risk primary prevention. Then the stage B, where there are patients who have some problem in the heart, but they are still asymptomatic. So these patients, in the echocardiogram, if the LV ejection fraction is less than 40, you can start on ACE inhibitors, right? And the same way it is ARB, beta blockers, and if the LV ejection fraction is very low, and there are some, say for example, patient can live for more than 1 year, we can talk about it, ICD treatment even in implantable cardioverter defibrillator. Where the ventricular tachycardias or ventricular arrhythmias are one of the common reasons the heart failure patient die. So by putting the ICD inside the heart, we can put a defibrillator that can immediately identify and shock and prevent the death occurring, right? And the genetic counseling, all those things can be done for stage B heart failure. Symptomatic heart failure with ejection fraction. So heart failure, the EF is more than 50, and patient is symptomatic. The main line of treatment is diuretics. Then the new treatment, because we are lacking a lot of evidence to treat this preserved diastolic dysfunction heart failure. Previous, say a few years ago, we did not have anything to offer. Now there are new evidence coming up. The empagliflozin, this group of medicines are beneficial for this group of patients. The others, according to the symptom, you can start on this treatment as well. Symptomatic with mildly impaired ejection fraction. Again, the EF is 41 to 49. The diuretics are the mainstay. The green color, as I said, for every patient, if there is no contraindication, you should administer. Yellow is the one should be considered. So again, this group come up very high in this group. But unlike the reduced ejection fraction, the other medicines are coming at a 2B level where you may use it, right? So this is a bit of a comprehensive slide. This is the main theme of today's talk. That is the stage 3 heart failure and the stage D heart failure, where they have symptoms and low ejection fraction. All the greens you can see, these green lines should be considered in all the patients unless there is something which is preventing, like a contraindication or financial thing. So this is another new sort of group of medicine. We have a lot of evidence, ARNI, right? So sacubitril, valsartan, it's a combination of medicine, which is even earlier we used to say ACE inhibitors, that is enalapril, captopril, that group of medicine. Now the backbone, the first sort of treatments are like beta blockers and ACE inhibitors. Now if we have this group of medicine, that comes above the ACE inhibitors, right? So we should consider this, but unfortunately it is available in Sri Lanka in private sector, not in the government sector. The cost is very high. Each day we need to spend about 400 rupees, which is not affordable. And the beta blockers, like 3 beta blockers are very important: bisoprolol, metoprolol with extended release ones, or carvedilol. These are the 3 medicines. So once the patient is coming to you, SLL Health, and sometimes for ECG, discharge or summary, whatever it is, you could see whether these medicines are included in these patients. And if not, it is why. You can ask the doctor. Don't be afraid to ask a question, anybody, right? So if this initial line is administered and still the patient has less ejection fraction, then you can consider the additional treatments, right? So less than ejection fraction, then you can go for, according to the symptoms, if it is black people, the hydrolyzine nitrate is a very good mode of treatment. It has a lot of benefits. And the ICD treatment I was talking about, if the ejection fraction is very low, survival is good. If there is a LBB phenomena with more than 150, the wide QRS complex, so you can go for either ICD or CRT, where the heart is, the left heart and the right heart is now functioning at a different timing. That's the problem in heart failure. That is called dyssynchrony. By putting this CRT treatment, we can make this coordination again back to normal. That is both mortality and the morbidity benefit. So these all green lines should be considered in appropriate setting. So if the patient go into refractory heart failure, then we have selected other diuretic therapy, sometimes heart transplant, mechanical, that's artificial heart, mechanical circulatory support. We have left ventricular support and the right ventricular, both are available, but not, unfortunately, not yet in Sri Lanka. Heart transplant, we tried in Kandy, couple of heart transplant, but the program is not functioning now. If everything fails, then you have to go down the palliative pathway where we can symptomatically treat. These are the maximum doses of medicine. This is another thing as nursing officers and other staff we should consider. Each medicine has a target dose. Sometimes we are treating at a very minimal dose and stays there. Enalapril 1.25 or 2.5 for life, it is there. But unfortunately, if you see enalapril, we have to go up to 10 to 20 milligrams per day. So you can ask the question why it is not increased. Likewise, any medicine will have a maximum target dose where we try to reach that level if possible. And these are some of the additional therapies, like ivabradine is a new medicine where if there's a beta blocker is contraindicated, you can consider this. Or if there's a beta blocker, patient is on maximum dose of beta blocker, still patient's heart rate is more than 70 and sinus rhythm, you can consider it's a yellow. It's a good medicine. Then other medicines like digoxin and all, we were talking a lot of things about digoxin, PUFA, and these things earlier days. It's a fish oil. These are all 2B evidence, so you might or might not give in appropriate patients. I'll skip these few slides. I have only 1 minute. So this summarizes everything. It's a very crowded slide, but it put everything together, right? So the green ones in the first line of treatment for any heart failure with reduced ejection fraction is this 4 group of medicines should be considered unless there's a contraindication. Next, if the patient is very symptomatic, as Nilushka said, it is a fluid accumulation which is the main problem which is causing the symptoms. So we need to take the fluid out. Diuretics are main line of symptomatic treatment. Then you can consider about the CRTs, right? That is again in the green box, and ICDs in the green box on this side. So that is the ischemic etiology. If the heart failure is due to ischemia like MI, then the ICD is one of the main mode of treatment. And all the other things are like valvular heart disease, everything is given here. Later on, if you are uploading these presentations, you can slowly go through these and ask your nearest doctor or cardiologist regarding further management, because we can't be giving each and every information in 15 minutes. So this is one thing as LLD health that we need to consider, because although we are giving the most evidence-based treatment, sometimes patient might not be taking these medicines. So cognitive impairment, depression, substance abuse, frailty, all these things can be considered. Say, for example, if the patient is with you in the ward, you have a lot of time to talk to them. Please talk to them. What are the barriers, right? And address them. Lifestyle modification, we know. And a word about inotropes. Usually we don't administer inotrope in these patients unless acute heart failure and the pressures are low. But if the patient is on a program for a heart failure, the heart transplant or assist devices, then bridge therapy or palliative care, as a palliative care therapy, we can go for inotropes. So these are the take-home messages. Heart failure is a serious condition with very high mortality and morbidity and economic cost. That is the most important thing now. Early detection and appropriate management of at-risk patients and pre-heart failure patients are very important in heart failure prevention. And provide patient education, lifestyle modification, and cardiac rehab. That is, Nadija will be talking cardiac rehab. And consider these evidence-based medicine must in all patients unless there's contraindication. Device therapy is well established. We have CRT, we have ICD, but short of our left ventricular or right ventricular devices. And mechanical circulatory support and heart transplant are well established mode of treatment in advanced heart failure. Thank you very much for your care.
Thank you, Dr. Saki, for the wonderful lecture.